Megaloblastic anemia means cells with MCV greater than 100 and with megaloblastic changes. Megaloblastic changes. 1. Large nucleated erythroid precursor. 2. Nuclear maturation lags, no condensation of chromatin. Causes of megaloblastic anemia. 1. Vit B12 deficiency. 2. Folate deficiency. 3. Thiamine deficiency. 4. Orotic aciduria. 5. Drugs inhibiting DNA synthesis. Cytarabine, hydroxyurea, *6 mercaptopurine. MCV greater than 100 with normoblastic changes cause 1. Bone marrow failure MDS, aplastic anemia. 2. Liver disease. 3. Scurvy. 4. Hypothyroidism. 5. Alcoholism. 6. Brisk reticulocytosis. 7. Post-bleeding. 8. COPD. Morphological changes in smear of MDS. Macrocytes. Megaloblastic, sideroblastic. Major cause of Vit B12 deficiency and folate deficiency. B12 autoimmune plus GI pathology. Folate, nutritional. Vit B12 in diet is in what form? Adenosylcobalamin, methylcobalamin. Vit B12 absorption step in stomach. Combines with R factor, haptocorin to form complex. Vit B12 absorption step in duodenum. Pancreatic enzymes split the complex. And Vit B12 combines with intrinsic factor secreted by parietal cells. Vit B12 absorption step ileum. IF Vit B12 complex plus cubum receptors. Released into circulation. Vit B12 absorption step in circulation. Binds with transcobalamin 2 to form holotranscobalamine, which reaches marrow. Which cells are present at base of stomach and they secrete what? Chief cells pepsinogen. Parietal cells are located at what place in stomach? Body neck isthmus. Secret HCl plus intrinsic factor. Causes of Vit B12 deficiency. 1. Autoimmune pernicious anemia, antibody against parietal cells plus intrinsic factor. 2. Ileal disease, Crohn's, tropical sprue, TB. 3. SIBO. 4. Fish tapeworm, Diphyllobothrium latum, infection. 5. Congenital transcobalamin 2 deficiency. CUBAM mutation, Imerslund-Grasbeck syndrome. Transcobalamin 1. Produced by granulocytes, high in MPN. Causes increased binding capacity with Vit B12. Transcobalamin 2. Produced in all tissues, especially liver. Important role in transport. Transcobalamin 3. Some role in transport. Function of Vit B12. Act as cofactor in 2 process. 1. Homocysteine to methionine. 2. Methylmalonyl A to succinyl-CoA. Folic acid different forms in food circulation storage functional. Monoglutamate food, 5-methyl-THFA circulatory and storage. THFA functional. Which reaction of folate need B12? 5-methyl-THFA to THFA need B12. This reaction is simultaneous with homocysteine to methionine. What's folate trap? Due to B12 deficiency, accumulation of 5-methyl-THFA occurs, as it can't be converted to methionine. Causes of folate deficiency. Nutritional, celiac disease, pregnancy, growth, hemolysis, increased demand. Drugs. What all drugs cause folate deficiency? Methotrexate, sulfosalazine, PPI, pyrimethamine, triamterene, phenytoin. Normal Vit B12 level. More than 300 pg. Levels of methylmalonyl-CoA, serum folate, homocysteine in Vit B12 deficiency. All increased. Earliest change in megaloblastic anemia. Hypersegmented neutrophils, greater than or equal 5 lobes. Features of dyserythropoiesis on peripheral smear. Cabot ring, basophilic stippling, Howell-Jolly bodies. Can pancytopenia seen in Vit B12 deficiency anemia? Yes, but in severe long-standing cases. In pernicious anemia, the autoantibodies formed are sensitive and specific for sensitive, anti-parietal cell antibody, specific anti-intrinsic factor antibody. These antibodies are autoimmune. Manifestations due to autoantibodies in pernicious anemia. 1. B12 deficiency. 2. Hypochlorhydria, hypergastreinemia, obid pain, ulceration, diarrhea. 3. Antral sparing with body involvement. Autoimmune associations of pernicious anemia. Addison, type 1 German mark, vitiligo. Clinical features of megaloblastic anemia. 1. Skin and mucosal changes. 2. CNS changes. 3. GI symptoms. 4. Pallor. Skin and mucosal changes in megaloblastic anemia. Angular cheilitis. Atrophic glossitis with beefy red tongue. Hyperpigmentation. CNS changes in megaloblastic anemia. Spinal cord involvement. Posterior and lateral column involvement. Peripheral neuropathy. Late changes cortex, optic nerve. GI changes in megaloblastic anemia. Higher risk of cancer. Gastric carcinoid 1 greater than gastric adenocarcinoma. Is there spinal cord involvement in folate deficiency? Nope. Treatment of megaloblastic anemia. Lifelong B12 supplements. Hydroxycobalamin, 1000 microgram OD for 1 week, then weekly for 1 month, then once a month every year. Ready count begin to increase and reach max, as response to treatment. Begin to increase by 2 to 3 day. Max by 6 to 8 day. MCV comes normal after how many days of treatment in megaloblastic anemia? 10 weeks.